Thanks very much, and thanks for the opportunity to discuss these very important papers. Things have changed in colorectal cancer management in the last 5 years. We passed from an approach of first line, second line, third line, to first line maintenance and then reintroduction, or second line if the maintenance was short enough. Now, the three papers I'm called to discuss regard the three parts of this paradigm. The BABIP trial regards the second line. The FIRE3 regards the induction period of treatment of this disease, and the SAKK regards the maintenance. I will mainly concentrate my discussion on the FIRE3, although I devote 2 slides to each of the other 2 presentations. Now, the BABIP trial substantially emphasizes the results of the TML data. I'd just like to call your attention to this number down here, that 50% of the patients had a bevacizumab-free interval before entering the study of Bev beyond progression longer than 3 months. So this is not Bev beyond progression. This means Bev continued, then stopped, then reintroduction of Bev. And that may challenge the paradigm. We know that bevacizumab works in first line, in second line, beyond progression. Now we have the challenge that Bev works even beyond progression with breaks. So I wonder, and I leave up to your thoughts, what happens to the concept of using Bev until progression, if this is true. Again, this is just hypothesis generating. Second trial, the conclusion of the SAKK. I had problems with this. The more I read this, the less I understand it, because not continuing Bev maintenance is not non-inferior to continuing it. Again, I know statisticians are kind of perverted because they reject the null hypothesis instead of justifying what you want to describe. But this is not rejecting the null hypothesis, and I have problems with this. So I summarized it in this way. Continuing Bev alone as maintenance is not so efficacious. That's essentially my take-home. Okay, so again, I don't want to be too much iconoclastic here, but okay, but I'm a clinician, so where do we stand in terms of maintenance with Bev? We have the macro study that, again, in lay terms, showed slightly bevacizumab alone being slightly inferior to continuing doublet chemo plus Bev. Okay, fine. Then we have the KRAS study showing that continuing Bev and CAPE is good. And then we have the SAKK saying that continuing Bev affords a minor benefit. Conclusion: Bev plus fluoropyrimidine are okay as maintenance, and that comes from 2 studies, KRAS3 and CONCEPT. Bev alone as maintenance does not look as promising, but as conclusion, we have to wait for the AIO 207 for final assessment of the value of bevacizumab alone. FIRE3. First point, the more I concentrated on the patient characteristics, the more I caught this trend toward a slightly worse patient population in the cetuximab arm. Also, there was a shorter induction and shorter maintenance in the cetuximab arm. So if anything here, we are stacking cards against the anti-EGFR. Again, minimal changes, but that's quite constant. Second point, same second-line use of oxaliplatin, same crossover with biologics, and same use of biologics beyond progression. On top of this, the activity and efficacy data, same response rate, same resection rate of liver metastasis. That was a comment made at ASCO. The same disease control rate, actually favoring a bit bevacizumab, and same PFS, good, 10 months. In spite of this, we had the unexpected finding of a relevant 3.7 and statistically significant 3.7 months gain in median overall survival for cetuximab. But what is remarkable is that all the gain is in the post-progression survival, time from progression to death. That is where we see the difference. And on top of all that, if you look at the tail of the curves, you have 50 to 100% proportional increase in long-term overall survival, which is a pretty compelling evidence, although the number of patients shrinks down. But again, this is a huge study. Don't say that this is a small study. This is a 700-patient study on KRAS wild type. So whenever we have to interpret this, we should address these three questions. Is this new? Yes, this is the first head-to-head comparison. Second, is this true? And third, if true, is this relevant? If it is true, because we can exclude bias and chance, then our practice should be changed now because of the relevance of the data. If we are uncertain about whether or not this is true, because bias may be an explanation or just chance can be an explanation, then we have to wait for the CA-LGB study addressing pretty much the same question. So let's analyze the most important part of this study. What's the hazard ratio in the first part of the curve here? 1. What's the hazard ratio in the second part of the curve? They run parallel. It's 1. So what's so magic? That's miracle. In between. The hazard ratio there is 0.4, 0.5 in that stretch. Okay, so that's first inconsistency. Little plausibility of the curve. That doesn't fit into a humane paradigm. Second problem. You treat it for 5-6 months, and then you see the effect 18 months later. Oh, that's a stab. Third aspect, same response rate, same resection rate in the liver, same progression-free survival. Oh boy, and still you see this. Now this impacts on plausibility of the data. Now, to answer if it is true, we have to address 3 aspects in between science and philosophy. The internal validity, science. Now, you see that now high, and that's written in red and underlined because I'm so grateful to the German investigator for their fantastic work in identifying all the second, third, and fourth line treatments. And in this way, they are raising the internal validity of the study to such an extent that bias becomes less likely. So thanks very much. This is a very nicely conducted study. Although the internal validity is damaged by that crazy choice of response rate as primary endpoint. That doesn't even fit in the definition of a phase 3 study. That's a contradiction in terms. You don't run phase 3 studies with response rate. Still, this presentation is so much more important than the presentation made at ASCO in terms of raising the internal validity. We may discuss this. The second aspect is the internal consistency. How do the numbers jive? How do they square? Well, the internal consistency is extremely low. And finally, plausibility. I have a problem with this. Although the peak study, if you think of it, produced exactly the same pattern of behavior of the divergence of the curve. See, 24 months later, after the beginning, the curve diverged by the same extent. So let's not be too sarcastic about the low plausibility of this. That's my point. So, conclusion, again, of course, the peak was a randomized phase 2. I think Alan Venuk will be discussing this later. Okay, and used oxaliplatin as a backbone, and it was on the all RAS wild type. So, to conclude, and this is my last slide, are the results true? Well, we cannot be sure. What we can be sure is that the probability that bias has played a major role in determining these results is kind of nullified, minimized by the so accurate presentation by the German scientist. But that cannot exclude chance. And because of the low plausibility and low internal consistency, chance can still be an option. So I would personally wait, based just on the FIRE3 data, not on the other data on all KRAS that will be discussed later. I would be inclined to wait for the CALGB studies, and if the results are similar, then I would change my practice, even if no good explanation will be found. Josh Fiedler used to say, the data are the data. If you cannot find an explanation, change your idea, but you can change the data. Thanks very much.